First of all, I would like to say to Cordula for joining us for this Zoom meeting. And this year we decided to have a Zoom meeting every month about the spine oncology. So we have great experts. We started with Jeremy, and now we are together with Cordula, and we will follow this every month, I guess, till to June. So once again, thank you very much. And now it's your time. Tell us what you are doing in Basel, and we would like to get your experience.
Thank you, dear Ufuk. Thanks for the invitation. I really appreciate it a lot. Maybe I introduce myself really short. So my name is Cordula Netzer. I'm Deputy Head of the Spine Center here at the University Hospital in Basel. I'm a senior consultant for spine surgery. So I'm coming from the orthopedic trauma surgery, but focusing on spine surgery and especially tumor surgery since 10 years here in Basel. And as for the topic today, I decided to give you a case-based, to share my case-based experience about primary sacral tumors. So, oops, doesn't move. What happens here? It's frozen. Okay. So I have no disclosures for this topic today. Here I just put up a graph from our annual surgery statistics. So our spinal department is performing about 1,000 spine surgeries per year. And as you can imagine, the tumor part is, as everywhere else, in percentage quite little. So in total, we see about 6% of our surgical patients are tumor patients. And but this is including the metastatic patients as well. And as for the primaries, we see in the average maximum five patients with primary tumors per year. So this is very little, but as you know, Switzerland is very small. So and every university hospital takes care of spine tumor patients. So it's just what the percentage is over the whole population. From my tumor background, I would just let you know that I had the great chance to do 2 long-term spine fellowships, one with Professor Boriani in Bologna, and the other one was a couple of years ago in Budapest, Hungary with Dr. Varga. Maybe you heard about this meeting. I was very lucky to have the chance to invite those very experienced tumor people to Switzerland. So we were able actually to have 2 series, let's put it this way, of the originally BB spine meeting, and we converted it initially to the BBB, so Budapest, Bologna, Basel spine meeting the last time, because Professor Boriani moved to Milano, so it was named BMB spine meeting, which is a meeting with international experts in tumor spine surgery, and so we had a great chance to meet all these people and invite all these people here to Basel. And one more thing about the networking we are doing here in Basel. So we're part of the AO Spine Knowledge Forum Tumor. I'm one of the associates there, and we are participating in the register study, the so-called MTRON study. This is a study for metastatic patients. And this is an ongoing thing for I hope for a long time, which is very important to collect all those data for developing further treatment concepts in this specific diseases. But now let's come to our topic today. So as mentioned already, I have chosen four cases of our university hospital here, which we performed the last years. I would like to start with the two patients who did have the osteosarcoma in the sacral spine, and then followed by two patients with the chondrosarcoma of the spine. All of our patients are, of course, discussed, and I think this is the global sense right now that discussion in a tumor board makes sense. So all of our patients are included in this specific tumor boards, which usually takes place once a week. And as you all know and aware of, all the disciplines which are involved in the specific treatment of the tumor. So we have a board for bone and soft tissue tumors, where specifically those cases are discussed, and all the experts are included in this board. This is an algorithm I would like to share as well. It's an internal algorithm, which I think is really important to treat patients with primary tumors properly. It makes sense that the patient, if you include him or her to the board, that there has been done a certain staging already. It's not really obligatory, but it makes sense to have the staging already. If you don't have it, it makes sense to discuss it anyhow and follow up the patient with the staging. And this is really something I would I have placed it later on in the presentation. The biopsy absolutely necessary to do it in the center hospital. So you shouldn't allow, or you should do everything to avoid that the biopsy is done outside somewhere, because if you don't do the biopsy properly in the spine, especially in the spine, or now in our cases in the sacrum, it can really end in a big disaster if you've chosen the wrong trajectory for doing the biopsy. So usually try to include the patient to the tumor board and make a proper decision on the biopsy channel before doing the biopsy. This is really important. And of course, if we have all the data, including the histopathology, we can determine the temporal order of the treatment of the patient. So whether to do surgery, or before surgery do the radiotherapy or chemotherapy, etc. I will discuss this later on, but just to get the timeline here. And of course, if you plan surgery in those kind of patients, you have to define, and usually the goal of primary surgery is a curative intention, but you have to make a proper decision whether you want to do and to reach with your surgery. This is unfortunately written in German, but I did write for an oncological journal. I collected all the data available on therapeutical options in sarcoma of the spine, and divided the three main diseases of the primary tumors, the osteosarcoma, chondrosarcoma, and Ewing sarcoma, for each different pathway. And the focus now, as I mentioned already, are patients with osteosarcoma, 2 patients, followed by 2 patients who did have a chondrosarcoma of the sacral spine. As you might know, the osteosarcoma is a chemosensitive tumor. So usually before doing surgery, patients are are put on chemotherapy. And usually there are some more serious after the surgery. So the oncological specialists have to be involved in the whole concept from the beginning in the board. And the radiotherapy actually in osteosarcoma does not play a big role. So sometimes it's done as an adjuvant. One of my cases will show you an additional treatment which was necessary because of some problems we had with radiotherapy in osteosarcoma. And I will highlight this image on the right side later on. So let's come to the very first case. When she was introduced to our department, she was 16-year-old. Now she is 19-year-old. So this is almost 4 years down the line. She, as most of the patients, she was complaining about pain, and they did in a rural hospital here. They did some imaging and detected a big tumor mass here in the sacral region, and so they introduced her to our board, and we decided to go for a CT-guided biopsy. And did, of course, the complementation of the whole staging, which luckily showed that she didn't have any other metastasis. So this was a single lesion here. And as you can imagine already, the tumor is involving the foramen and therefore the nerves, S1 to S3 on the right-hand side. So S1, S2 have been wrapped by a huge tumor mass on the right-hand side. This is the MRI. You can see the alterations typically for this kind of region here. Actually, in the imaging, you will see it a little bit better on the next slide, because this was our problem. In the imaging, we didn't expect that there would be tumor beyond the sacroiliac joint. So we checked therefore, and here everywhere it looks as if the ileum itself is totally free. As said, I will come to this later, but so this was the image and this was the tumor. And according to the protocol in the board and the international available data, we recommended to do some neoadjuvant chemotherapy before surgery, which she received. No further problems at this time, and we decided to go for a block resection and reconstruction. As for the surgical part, we decided to do a protective colostoma and a suprapubic catheter before surgery. Actually, this decision was because usually in this region here, there's a high risk for surgical site infection, and if sacrificing some of the sacral nerves root, there might be a problem with the continence, control of bladder and fecal incontinence, and because of the proximity to the incision and the wound in this region, in this specific cases, we most of the time talk to the patients and recommend treatment or protective surgical procedures like this. So this is what we did in preparation, and then we were planning our en bloc. So the goal was R0. So we want to have it completely out the tumor. We decided to sacrifice the nerve root S1 and S2 on the right-hand side. And actually, we were planning to do the osteotomy with specific guides, 3D printed guides. I will show you this later. And as for the reconstruction, our intention was to use autologous fibula graft harvested from the right leg. And of course, we involved from the beginning, we involved our colleagues from the plastic surgery to do the wound closure and the soft tissue handling with gluteal flap. This was the planning for doing the resection. So we using those 3D models, and as mentioned already, we have 3D printed guides, which I think they're on the next slide. Yeah, exactly here, which are how to say, which we put on specific landmarks, and then according to these landmarks and the guides, we can go for osteotomy very precise and in a good distance to the tumor, usually, not in this case. This is how it looks like. Yeah. So usually we have specific saws which fit, which are specifically designed for this single surgery, which fit into this guides. And actually this, and we still don't know why it happened in this case, but obviously there was, well, the incision we did with this guide was we controlled it thereafter. It was correct, so we did what we want to do, but obviously there was little spread of the tumor already beyond the sacroiliac joint, so we couldn't see it in the imaging before. And we actually don't really know what we could have been done to avoid this problem, but this was, in this case, yeah, was a problem thereafter. This is how it looked after the surgery. So I did the instrumentation, and we did the reconstruction. As you can see here, we are with the Harms cage and with the fibula here. So this is the fibula, and I filled the Harms cage additionally with autologous bone graft to get a good fusion here. Yeah. So yeah, as mentioned already, we unfortunately in this case we only reached our one resection because of the tumor spread to the ileum on this side here. Otherwise, the patient was doing really well, so she could walk with walking aids. She had to do a partial load with her right leg. That's what we recommended for the first 3 months. But had after putting back the ileostoma, she had full bladder and bowel control, so no problems with this neurological function there. What she did have, and actually this is still her problem, is a severe neuropathic pain for the S1 nerve root, which we sacrificed, and of course the corresponding weakness of the S1 nerve with the weakness of the in the foot. So yeah, as said already, we relocated the protective colostoma, no further problems. And after the result of the histopathology of the tumor, which we sent in for examination after surgery, we discussed again the whole situation in our tumor board. And then in this specific case, I told you before that radiotherapy does not have a big, does not play a big role in osteosarcoma, but in this case, we decided to go for radiation therapy. And because of the special location and situation, we decided to go for proton beam therapy. So we have one center here in Switzerland where we can send our patients for the specific therapy. And well, that's what we did. And she tolerated quite well. She could finish chemotherapy thereafter. She was doing good actually for the first year. I've seen her regularly. She needed some pain medication, and the S1 problem was what she annoyed a bit, but otherwise she was really good. And then she called me because she had a sudden pain, a severe pain in her low back. There was no trauma, nothing, but she had this implant failure here, as you can see here. There's a breakage of the rod. So where we decided to go for revision surgery. And after surgery, this was the result here. So I did, my intention was to refresh all the bony structures here and to do to attempt a refusion with, again, autologous bone graft here. This is now actually 2 years down the line. So 3.5 years from the first surgery. She's doing really good. She's attending a business school. She's driving a car, specific car, which she can use with her weakness in her foot. She's riding a bit, doing some winter sports. The only problem right now she does have is the S1 radiculopathia in her right leg. So this is still a problem. But it's not deteriorating, so I hope there will be a stabilization over the time. So next patient. This is a patient from Nepal. Actually, they called us because they were looking for somebody who can perform surgery on this patient. It's a 20-year-old Nepali, which was diagnosed with chondroblastic osteosarcoma. They did the biopsy in Nepal and were just contacted us, and then we were discussing whether and under which circumstances we would be able to offer him some sort of surgery. And this was the imaging. This is the MRI from Nepal. The quality was good. And as we can see, it's a large lobulated mass arising here, the right side of the pelvis, involving the right ala of the sacrum, and the sacroiliac joint is completely within the tumor here. And he didn't have, his problem has been pain, so he fortunately didn't have any neurological deficits. This is another view of the MRI, so you can see the large tumor mass here. Again, here the CT with the large tumor mass here. Here the muscular is pushed away by the tumor mass. As said already, the biopsy was done in Nepal. This has been the results, chondroblastic osteosarcoma. So, and the staging in this case as well didn't show any other further spread of the tumor. So that was good for him. Well, we had to discuss several issues with the patients. So of course they didn't have any insurance here. They did have some relatives living here in Switzerland. So they were actually going for crowdfunding to cover for the costs. And we were discussing in the tumor board what kind of surgery and treatment we are able to offer him. And since explained before, in the osteosarcoma, usually according to the protocol, it makes sense to start with a neoadjuvant chemotherapy before surgery. So this is what they did in Nepal. And then we explained him by phone what the surgical options are, and he decided to go for the surgery. knowing that there would be some relevant potential risks and deficits which he has to take into account after surgery. So the idea was, again, here, the wide resection, including the iliosacral joint, was part of L5S1, part of the sacrum ilium, and doing a spondylodesis L4 to the ilium, and the reconstruction. Actually, we decided to do a vascular, to do it with a vascularized fibula graft. Well, I will show it later on. It's easier if you have the image here to get an idea. So this is actually what we were planning to do. So do the resection of the sacrum here and the ilium here, and remove this whole part here. This needs proper planning. Again, we did the 3D modeling of the tumor, and we tried how to work with our guides and prepared all the necessities for getting this straightforward done. As you all know, you need a lot of things to get this kind of surgeries done, and we, in this case as well, we involved the plastic surgeons right from the beginning. So you see here in the image here the harvesting of the vascularized fibula graft on the right hand side. So we were well prepared. I started with the very easiest part of this surgery, putting in the screws and give the whole construct a bit of stabilization on the contralateral side. And then I did the surgery together with my colleague, which is specialized in orthopedic tumor, all kind of orthopedic tumor surgery. So he was taking care of the pelvis part, and we had the plastic surgeons who were taking care of the soft tissue and muscular flap situation to get this big lesion after removal of the tumor nicely closed and covered, because as you can imagine, there's a big hole after removing this large tumor mass. And this was actually the result after many hours of surgery. So we managed to remove the whole block so it was a R0 resection. So we had it completely out, and we managed to put in this was from our experience, this was a quite tricky part to really put in the screws without having the normal anatomy anymore in the surgical situ. So we had to completely rely on our 3D guides, and managed to put in those screws with a really good grip, and did the reconstruction as you can see it on the right hand side. This is just a picture of the vascularized fibula graft, as you can see it here. And we put it in here, and the plastic surgeons, they connected it to a big vessel here of the gluteal arteries. This is how it looks after surgery. When it was quite a big impact for the patient, I think blood loss was quite high. We needed 11 erythrocyte concentrates, etc. But altogether, he really tolerated very well, and the surgical outcome was as we hoped with the R0 resection. So he could actually be mobilized quite fast, again with a partial loading of the right leg. He had some pain, but not severe pain in the right leg. And of course, as expected, he had weakness in the right foot. And this was actually after 2 or 3 days. So he was up very fast. And this is 1 week after surgery, the X-ray control, which looked good. Again, we did the reconstruction. I have a short video. Actually, this was 4 weeks after surgery. I hope it works. Where do I have it? No. Otherwise, I skip it. It was a video showing him walking. No. No, my presentation is gone. Sorry, I have to restart somehow. Sorry, I have to restart the whole presentation. Completely shut down everything. Sorry. Okay. Where am I? Okay, now we are back, but without video. Actually, this image just arrived last week, and so this is 1 year after surgery now. He's back in Nepal. He's doing fine. He is able to walk with one walking stick, but he's attending university, did his exams in computer science, and actually he this was in August, but now he doesn't need any pain medication at all anymore. So this is so far 1 year after this big surgery, for him a good situation. And the tumor, we do have the MRI. So far it was without any further tumor identification. And we haven't seen the one from the weekend yet, but I keep my fingers crossed that everything is fine. So let's come to the chondrosarcoma cases. They are a bit different in their treatment protocol. So they are neither chemosensitive nor radiosensitive. And so the only thing you really can do is go for usually radical surgery. There's one exception in low grade, so grade 1 chondrosarcoma. There you can go, and we know we have plenty of data from the extremities, orthopedic tumor patients in the legs and arms, where the data show quite good and satisfying outcomes if doing a radical curettage of the tumor. So not necessarily en bloc resection, but this is only for the low grade ones. I would like to start with the first case, 36 6-year-old female patient. She introduced herself to our clinic in 2017. So MRI was done because of pain in her lumbar sacral region, and we did see this tumor formation here. Again, we discussed the situation in our board and performed a CT guided biopsy, which showed in her case a chondrosarcoma 1, but with transition already to grade 2. So the decision we made was to go for en bloc resection. So with a curative approach of the surgery. And again, here on the left-hand side, the extension of the tumor below, below the nerve root S2 here. You see the extension here. And in this case, actually, we did the osteotomy with a navigated system. And on the right-hand side, you can see the result of the osteotomy of the tumor. I did what I sometimes do when performing extensive laminectomy of in the sacral region. I try to cover the nerves to protect them with a tiny small so-called matrix plate. So you can see it here in the CT, in the reconstruction. I just put it and fix it with tiny little screws. So it's like a wrapping around the nerve structures here to protect them from the structures around and from the pressure from outside. And usually this works quite well. And in her case, we received en bloc resection with clean borders of the tumor. As said, we did it in a navigated version, and to visualize the neural structures at the laminectomy starting from S1 going down all the way to S4. And the intention was, because of the spreading of the tumor, to sacrifice the nerve root S2 and S3 on the right-hand side. And again, we involved our plastic surgeons from the beginning, and they did revive flap of the gluteal region. And this looks usually like this. They do it on both sides to then do an overlapping closure of this region here. So they do it. They remove the upper part of the cutis and just flip one part of the flap down there to fill the hole. So this is what they did. It worked out well, but in this case, unfortunately we had a problem with the wound healing. So she developed a surgical site infection with this kind of bacteria I mentioned here. So unfortunately, we had to go for revision surgery again, of course, with our plastic surgeons, which did the release of the flap, and we cleaned everything. And after cleaning and doing a debridement of the soft tissue, I removed the plate because I didn't want to have a metal thing in this infected situation. So I removed everything, cleaned everything, and then did do a wound closure again, and with the specific antibiotic treatment, she recovered quite well. So there were no further wound healing problems. As said already, we received our thorough or block resection. I have seen her regularly the last years. She has almost no pain, little sensory deficits in the areas where we removed the nerves. She had a little bit problems in feeling her bladder filling up at the beginning, but this did disappear over the time. So right now she doesn't have any problems with incontinence at all. Then story goes on. This was 2 years after the primary surgery. She developed, she's quite active, so she does a lot of yoga and things like this. And she developed a bump in her lumbar spine. Of course, we did the MRI because on the routine MRI it was not in the we didn't see it because the routine MRI and the follow-up was going only up until this region here. So we did another MRI and we have seen this problem up here. What to do now? We decided to go for a biopsy. Our radiologist mentioned that it could be a desmoid cyst or something like this, but we could exclude this with a biopsy. And then we discussed again what to offer her now in this situation. And since even we knew from the biopsy that it's not very likely that this lesion is associated to the primary tumor, we decided to remove it en bloc. And the histopathology of this second tumor was a myofibroblastic spindle cell tumor. We had it out in we did the complete resection again. So this problem was solved as well. Now it's 5 years. So she's still tumor free. She's in a very good condition, working full time, does sports regularly, has no restrictions in her daily routine. As said already, she does have a bit of numbness, but not a problem in that it disturbs her or anything like this. So last patient before coming to a conclusion is a 50-year-old male patient with a chondrosarcoma. This was as well a patient which we've seen back in 2017. He was introduced to our clinic with this lesion here. So there was an extension again to the epidural spinal canal of the sacral region here, compression of the S2 nerve root on the left-hand side, and severe compression of the cauda equina down here. These are the coronal images and the axial images. So again, we did the CT guided biopsy, and now we had actually a chondrosarcoma of first degree. So in his specific case, actually I asked some of my other tumor colleagues from our network what to do in his specific situation, and we discussed it in the tumor board. And in his specific case, because it was we were very sure that it was only low-grade chondrosarcoma, we decided to go for a radical intralesional resection of the tumor. The comorbidities are psoriasis and some obesity and severe coxarthritis actually on both sides. This is the corresponding PET CT and the CT down here. You see the extension of the tumor. And again, here our decision to go for intralesional tumor debulking. So the idea was to preserve the nerve roots, so do the debulking around the nerve roots. And actually what we thought might be a good idea, because you have seen the lytic lesions, and if it were additional intralesional debulking, we might weaken the bone. In this region, we thought we are going for a unilateral stabilization, as you can see it here in the image. You can see the big decompression area here and the stabilization. Unfortunately, now in the intraoperative biopsy, we suddenly had so there was a transmission to degree 2, so it was not a low grade anymore. And this was something which made us to rethink the whole concept. And we were discussing the situation and decided to recommend him proton beam therapy. And that's actually what we did. He tolerated well, no further problems here. Actually, in the follow-ups, there were no signs of tumor, of left tumor. There were no signs of recurrency. So all in all, after proton beam therapy and the intralesional curettage, the tumor was according to the images, under control. His clinical outcome was okay. He had some pain. He could go back part-time to work. And he had some hip problems actually already before the surgery, before the tumor surgery. And they, over the years, they got worse. As you can see here, he had severe hip arthritis, left side more than the right side. So we were thinking that the problems he had in this region here were maybe coming from the hips. So we recommended to go for hip replacement, which he did actually on both sides. But the pain didn't get that much better. It was the opposite thing. The pain in the lumbar sacral region, especially sacroiliacal region, did get worse over the time. So we did, beside of the routine imaging, follow-up imaging, we did additional CTs, and as you can see here, he does have some insufficiency fractures here, actually on both sides, here and here. And if we have a look on the lateral aspect of this region down here, so this was shortly after the surgery. And if you have a look at the situation now here, you can see the dislocation. So he has like it's almost like a Chamfer's fracture. So it was three-dimensional fracture of the whole sacrum, and of course this creates pain. This was the according MRI. So we decided to go for revision surgery. As said, the tumors is not an issue anymore. There were no signs of tumor recurrency, but the severe insufficiency fracture probably triggered additionally after the proton therapy. There are data out that there's a correlation between insufficiency fractures and proton therapy. And And so this is what we did. I decided to go for for a safe construct, going down to the ilium on both sides with a double screw technique and this cross link, and going up to L3, L4 on both sides. This is now actually half a year ago. I will see him in 2 weeks again. He wrote me that he's doing okay. He could reduce his pain medication. He already started working a bit after the last surgery last year in autumn. So 4.5 years after the initial surgery, the result right now seems to be for him to provide a good life quality. So take home message from this 4 cases from our side here. If you do have a tumor with an unknown entity, always refer the patient to a center hospital, especially for the biopsy. We honestly, we have seen really big disasters after biopsies which have been done outside, intralesional, and terrible spreading of the whole tumor. And this is a pity and can really be avoided. So it makes sense to spread this knowledge to the people you are working with, that they shouldn't try to do things which might harm the patient. So always, try to deal and treat these patients in a center hospital, which provides adequate tumor board. And if doing surgery in this kind of patients, you have to be sure that you do have the necessitative infrastructure with all the other specialties in surgery, which I mentioned. So it's important to have the plastic surgeons on board, the visceral surgeons, the vascular surgeons, and you have to try to make good friends with all these other disciplines to really treat those patients in a proper and satisfying way. And even if you think you do everything right, as I've shown you in those cases, it's always a challenge, and there might be problems which you don't expect, even if you thought you've done the maximum you could do. So be prepared for complications, and before scheduling those patients for surgery, think of the other disciplines you might need for getting the problem solved. That's from my side here. Thank you very much for your attention, and if you do have some questions, I'm looking forward to try to answer those.
Well, thank you, Cordula. It was a very nice presentation and some different approaches. There are a few questions from my friends. One of them is, which approach do you use in which setting if you are dealing with sacroiliac tumors or partial sacral tumors? Do you do it in a lateral position, or you do it posterior, anterior? How do you do it? And if you do it anterior, posterior, when do you use the stage surgery?
Yeah, it depends. Usually most of the sacral tumors can actually be approached by posterior approaches only, because if you do the release of the tumor step by step, you will have enough space to work you through anteriorly. I always prepare everything as so in case I need to turn the patients because of any complications in the vascular area, wherever, that I can turn the patient around. But usually, even if doing in this cases or more, if you have to resect large parts of the sacrum, it's possible to do everything from posterior.
Okay, I assume that you work with Peter Vargas, so probably you saw some total sacrectomies done by only posterior approach, which Peter can handle this.
Yeah, actually, I've seen it. Yeah, I've seen him doing it. One thing when he did the total sacrectomy, the one case I attended in Budapest, he started from anterior, but this is because he's doing this ventral, the flap from the ventral side, from the abdomen muscles. So he released all the for the muscle reconstruction. He released everything from ventral, and then put the muscle flap to the posterior side already, and then turned the patient. But the sacrectomy itself was done from posterior. Yeah.
Okay, great. One of my question would be, what's the appropriate thing to have the MRI or CT just before the operation? How do you accept? I mean, if you have a CT, MRI, and PET scan 1 month before the operation, 2 months before the operation, 3 months before the operation, what do your acceptance?
Yeah. It should be done very close to the surgery. So especially if you do it in cases where you had chemotherapy before surgery, then you should actually force to get an update on your imaging. And I wouldn't accept anything which is older than 2 weeks, actually. 2 to 3 weeks. I think this should be the minimum.
Most latest one should be not more than 3 weeks.
Yes, I would say.
So do you have any problem with using the proton therapy with metal implants, or do they can they do it with the metal implants?
It's definitely in proton therapy, it's definitely a disadvantage to have metal implants. I tried the carbon implants. I have some issues with the carbon implants, but if they are available and if they work in those specific cases, they don't work in this lumbar sacral region cases, because you need specific screws. There are no ilium screws, nothing, so you can't really combine it with other instruments. So it's not an the carbon implants are not an option if you have go down to the sacrum. So far, it might change. And in any region of the spine, if you can use other implants and then metal, of course, it's an advantage. But it's possible. The planning is more difficult, but it's not impossible. So you still have the option to go for proton therapy with implant.
Okay, do you ever use carbon ion therapy for any reason in your department?
And no, we don't. We don't have it.
You don't have it?
And we don't have it, and we don't use it. There's one in Germany, in Münster. I know only one case.
Yeah. Okay. So for the chordomas and chondrosarcomas, do you still prefer the surgery instead of sending them to do carbon ion therapy?
Yeah. Yes, and well, it depends. the one case was a chordoma case, which we sent to Münster actually. And the other ones, we explained them the different options, and they went for surgery, but the lesions haven't been that large, so we had detected them in an early stage, and then of course surgery is easy. I think it's a different if you have this huge tumor masses, then of course carbon ion is a big advantage versus surgery.
Okay, that's all questions we have. It was fantastic to have you tonight, and I would like to send our best wishes from my colleagues and from Turkey to Switzerland, and hope to meet with each other in face-to-face meetings when we get rid of this COVID problem.
I hope so too. I really hope so. Thanks again for inviting me. It was a great pleasure. And yeah, if anybody else does have questions, just send me an email or contact me. Thanks a lot.
Thank
and
you.
have a nice evening. Bye.
Okay.
Bye.
Thank you very much to the colleagues that being together tonight. And we will be together next month at the end of the month with Aron Lazari from Budapest. You know that the Budapest is one of the best centers not only in Europe, but also for me in the world. And Aron is doing very interesting job after Peter Varga. So I will let you know that when we are going to have and what time we are going to have it. So thank you very much to every one of you, and have a good night.
Thank you. Good night. Bye.